Hello, everybody, and welcome to another ICA Sports and Fitness Science podcast, part of the ICA Chirocast. I'm Brant Hulsebus, chiropractor here in Rockford, Illinois, board member of the ICA Sports and Fitness Science Council, and I'm joined today by a fellow board member, Dr. Kevin Jackson. You want to say hello?
Hello there, and I'm happy to be on the podcast today. And I thank you, Brent.
I know you're in Pennsylvania. Where in Pennsylvania are you?
York, Pennsylvania, which is it's west of Philadelphia and north of Baltimore.
Right.
To
You
give you a
practice there with a pretty nice established practice, correct?
Yeah, I've been in practice. We've been in practice, as you know, I'm in practice with my wife Selena Sigafus Jackson, and former ICA president she is. We've been in practice for 34 years. Nothing compared to the Hustle Bus. How can I describe it as just a three generations of Hustle Bus?
Right. Three
Wow.
generations. Yep.
All at the same location?
No, my grandfather wanted to build a bigger practice in Byron, Illinois, and the city council told him chiropractic's a fad and it'll never last, and we don't want an empty building. So he gave him the middle finger and moved to this location. So, although the Byron clinic stayed open until 2 weeks ago, 2 weeks ago they closed it.
Really? How interesting.
So
Wow.
Grandpa
What
was
a,
right. So
what a legacy, eh?
yeah, yeah. Well, today we're here to talk about sports, and I take care of a hockey team, and we get together every year, all the sports chiropractors for the hockey teams. And there's one topic this year that dominated our entire convention, our conference, and that was head injuries, especially when it comes to concussions and subconcussive injuries and stuff like that. And I believe that's an area that you also have did a deeper dive into, correct?
Absolutely, absolutely. There's lots of misinformation out there, and there's lots of not concentrating so much on subconcussive impacts, but as you know, more concussive impacts, and that seems to be the subject of concern. But to be completely honest, I think subconcussive impacts happen all the time, every time, and create neurological dysfunction. And only chiropractors actually, I think, look at this phenomenon and are equipped to deal with this phenomenon. And I'm glad that you're having the podcast because I hope that we can get this message out to all our chiropractic friends and practitioners. But very, 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 very important stuff.
You want to give us a little definition of subconcussive, so in case people don't know?
Yeah, well, let's just take a concussion or a concussive impact. And of course, I think anybody who watches sports would know what a concussive impact looks like. Someone gets a great big hit. There's some type of injury that occurs. They're walked off the field. They go into a protocol tent. There's some type of deficit, which is it's a brain injury and a mild traumatic brain injury, and it's serious. And it occurs. It occurs frequently. But something that occurs even more frequent is a subconcussive impact, because every time that you either take an impact to the head or a body to body impact, anytime that there's torquing and twisting involved with the upper cervical area, the cranial cervical junction, you're going to compromise the vascular system that goes from the spine into the brain, the neurological system. You're going to impact the hydrodynamics of the whole system. So there's three systems at work that can be compromised. And the deal is this, is that you don't have to have a concussive injury to have a subconcussive dysfunction. So in other words, there's a distinct difference between the two. As I was trying to allude to initially, is that we are really good at looking for concussive situations now. There's all kinds of protocols, but we're really, really, really poor at identifying what is a subconcussive impact and what is the neurological dysfunction that happens because of it. And it's primarily because no one really specializes in that area of physiology except chiropractors do. And that's why we're on this podcast is our mission at the ICA is to turn more chiropractors into sports chiropractors, especially for this one situation. So
Now,
to go further on that, what it actually is, it's known as a subluxation. So what happens is when you take an impact and your head accelerates and your neck accelerates, well, your brain accelerates and your brainstem accelerates and the blood vessels. And so that acceleration of the head creates a shearing force that misaligns the upper cervical area. And as you know, it starts to compromise the sensory motor system, the autonomic system. It degrades the performance of the individual from an athletic standpoint, even an academic standpoint. even an emotional standpoint. And yet it doesn't show up on concussive or concussion testing. And yet it will show up on our chiropractic analysis.
A lot of people have these. I know I have a lot of new patients that will come into my clinic and they'll tell me, I'll show them an x-ray and they'll have a horrible cervical curve. They'll have a lower cervical spinous rotation and they'll tell me, is that just from sleeping wrong last night? And I tell them a lot of times it's not from one thing, it's from 1,000 things done wrong 1,000 times. Now, do you find these subconcussives are exclusively to one impact or could it be a series of impacts?
Yeah, so it could be from one impact that sets everything off. But basically, what you're alluding to is that it's from a lifetime of playing sports and little impacts here and there. It's like BJ Palmer said, if there's a slip on a sidewalk, but it's the accumulative effect. And I used to analyze a football team that I worked with. We had accelerometers in their helmets, and you could just watch the impacts occur. And there was a threshold for concussion. So the coaches and I were always looking for concussive impacts. But what's very, very, very more important is the accumulation of subconcussive impacts and the effect that it has on the biomechanics and the neurology of that upper cervical area. It's an interesting fact that as kids are now getting into high school, if they have the luxury to get an MRI in their brain or that includes their brainstem, we're starting to see changes in the white matter of the brainstem and the brain without a history necessarily of a concussion, or it could have been a concussion while they're in high school. But all those impacts from little league through high school, they add up, and those are the scary ones. No one is talking about that. No one is doing anything about that, but we're going to change that.
Absolutely. So when you have these, where is the area of the spine that you do most of your time researching or analyzing or testing to see if this could be a concern? You talked about the subluxation. Is there a primary area you're looking at?
Yeah, so it's going to be the upper cervical area. It's going to include the occiput C1 and C2. And there's specific tests or specific range of motions that you can do as a quick test on the sideline if you're looking. And it's important if you under great circumstances, if you knew these kids before they went into their athletic season and you had a baseline on them, that would be the ultimate. But there is, let's say you're a mom or dad and you just joined the team, there are just tests that you can do right away that lets you know if there's going to be a compromise in the biomechanics of that upper cervical area or the neurology of that upper cervical area.
So you've developed a protocol to use on the sideline in case you are suspecting this could have happened, as you talked about the one-time blow, or
Yeah.
maybe you watch the same 10-year-old. I know like 10-year-old boys, there's a huge size difference and they can be.
Oh,
And if you see the same kid 4 inches taller hitting the same kid repetitively,
yeah.
you can start to suspect something's not right. And you have the ability to go down and do a sideline assessment. Is that correct?
Yeah, yeah. It's very easy assessment. There's not a lot of tools needed. You could have no tools, or you can bring a couple tools with you. One of the easiest things to do as a chiropractor is just go through the three planes of motion for the neck. I'll just go over them real quick. It'd be extension and flexion, which would be the occiput. It would be lateral bending, which would be occiput and atlas. And then it would be rotation, which would be C1 and C2. And what we're looking for is sometimes it's very obvious. Someone will go through rotation. They'll say, yeah, I can notice a difference when I turn to left. I can turn better to the right than I can to the left. You can make an assumption that you're misaligned at your atlas. Your atlas is going to, if you can't turn to the left, it's going to be atlas posterior on the right. As far as the assessment is concerned, you just have to do a little bit of coaching with the person when you're looking through it. When you're working with kids, you have to tell them to slow down, take it easy. But once you get them settled down and tell them what you're looking for, you're not looking for pain, you're not looking for a major amount of stiffness. You're just looking for like a decreased movement going left or right. And one of the ways that I discovered over time, and this is just an incidental, is that if you're looking to have them help you distinguish if there's a change in the range of motion, which actually means a change in the biomechanics, and you're helping them. It's called a patient assessment. If you have someone, for example, turn to left, you have them go as far to the left as possible, stop, and then go a little further. And that's where they're going to tell if there's a difference when they go to the right and they go a little further. You're able to tell in that end range if there's actually a deficit there. So range of motion can be used as a primary indicator of biomechanical misalignment on the sideline if you're really good at it. You can do visual inspection yourself as the chiropractor, but if you can get the patient involved or the player involved, it makes it a really, really great system, because if you make an adjustment based on that, and now they have better range of motion. Let's say they were stuck in left rotation, you adjusted their atlas, and then all of a sudden they had better range of motion going to left. You know that biomechanically you made a correction there. And those are really objective tests. When you get down to the nitty gritty, it's just an amazingly easy task to accomplish, especially if the coach is looking or the parents are on looking. They can tell right away, and they are really into it. Moms are the best clinicians around besides the chiropractor himself.
I know that this is really important to use to get a good test and get good objective findings.
Yeah.
And I want to keep on this topic here for another minute, because I think you've even come up with a tool that you can use on the sidelines too, if this is really your passion, correct?
Yeah, that's correct. So besides doing the range of motion testing, so that one of the first things that I would do besides range of motion, I would just do a simple test with a infrared thermometer. I would take and check the left atlas and the right atlas, and just to see if there's any temperature differential. And all that's going to tell us if there's some type of imbalance in the physiology from the left to the right. And a great thing, I have a unit that I use. It's called an Exergen, and it has a readout on the bottom of it. And you can clearly see what the temperature is between the left and the right. And everybody wants to know what their temperature is, especially the person that you're testing, and especially their parents. And so when you make a determination, you can tell them what you're looking for. You're just checking the neurology left versus right. And if it's warmer by 0.5 degrees, from the left to the right or right to left, there's a change in the physiology, and that's associated with the neurophysiology and the biomechanics of the upper cervical spine. So if you took the range of motion, you went through all three planes of range of motion, and you coupled it with the Atlas faucet testing, and then if you coupled it with the grip strength testing, now you got yourself a tidy little biomechanical and neurological package that you can use on the sideline that demonstrates to everybody watching. It gives them a causation, or it gives them an idea of what it is that you're looking for and what it is that you're trying to fix. And that's what a subconcussive assessment is all about. You're not looking for a full concussion. You're looking for little parts of it, little biomechanical changes, little neurological changes, almost like a preventative type of system.
So imagine you have a release form and paperwork. You have all designed up for this, so you can walk down and give it. Because I'm assuming this is 90% of the time your new patient that you just met that's going to start practice with you, not somebody you've already been taking care of for years, correct?
Correct. So let's say you're in a situation like I was taking care of Little League football teams. So prior to the beginning of the season, you get informed consent that, hey, I'm the chiropractor and this is what I'm looking for. We're not going to actually be doing regular chiropractic care on your kids. I mean, they can and they would and they did. But if it's just someone who is not even wanting anything done by the chiropractor, doesn't think the child needs chiropractic care, what you want to do is frame it as a subconcussive impact assessment plan. And all we're doing is looking for biomechanical, neurological differences. And it gives you that ability to check them if there is an issue and you're going to adjust them. There's also a part of the form that says we can go ahead and do that. But I like to have parents are going to be present with me the entire time. Coaches are going to be present with me the entire time. But yes, informed consent is very, 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 very important. There is a legal aspect to the whole thing. Now, let me tell you something about the environment that usually gets created. Once one parent has a good experience, all the parents are on board. It's just like a magical happening. There's always going to be a skeptic in the crowd. There's always going to have someone, I'm not letting a chiropractor touch my child. But once they watch that you're interacting, and I might add that, with our system, with it's called the Jackson cranial cervical junction method technique, there's no diversified or hands-on. It's all instrument based. So if they're leery about having their neck cracked, it's a very gentle process. It's just using an instrument to adjust the atlas or the occiput or C5 or C1. It's very, very aesthetically pleasing. It doesn't look like anybody's going to be in danger. You can see the changes right away with the Atlas faucet testing or the grip strength testing, or let's say that we did Romberg's. Romberg's testing is another one that we use that's part of it. And the child just stands on one leg and they close their eyes and they turn their head left or right. And then if they lean or fall to one side, they get their atlas adjusted and they get rechecked. And everybody, I'm telling you, when you're doing this type of work, as you know, well, you might do more of your work in the locker room. So this type of work that I was doing is basically was either with lacrosse teams when my daughter played lacrosse, or football teams, little league football. But everybody, all the eyes are on you. And so once someone experiences a good situation, everybody's on board. And the big thing is this is what I wouldn't do if I was a chiropractor working with a sports team. I wouldn't, I diversified care is wonderful. I do it in my office, but to the onlooker that doesn't know the history of it, the story of it, it's just scary looking to someone. And especially if you're working with youth athletes, it's just concerning to some people. So that's why
That's
I
why I
like
like your Well, I love your system to do the analyzation and get the science behind what you're doing before you do it and be able
absolutely.
to have something to present to patients. I know a lot of times us chiropractors get kind of lazy in that kind of stuff. We just rely 100% on our palpation. We're just going to walk there and feel it. I'm the best. I can get this done.
Yeah.
You have to about the professional level. We X-ray all the players before the season starts. We have all their listings on the locker room wall. But I'm a girl dad, and I was told the moment I had a daughter that I'm going to go to sporting events and I'm going to be the only one in healthcare there, and someone's going to get hurt, and it's going
Yeah.
to be my job to go on the field and do something. So I carry a little trainer's kit in the back of my vehicle at all times just in case.
Yeah.
But I love the way you have the tools to actually read the temperature changes. I mean, that's what we learned chiropractic 101 when we first started learning how to adjust and find subluxation. That's the
Yeah.
oldest tool. So I want to dive more into your technique then and how you do the correction of the sideline as you started to allude to. But I think this is a good spot for us to end part one and have everybody come back for our next podcast and join us now. Now we know how to find the subluxation. Now we know how to get about doing it. Let's do part two now about the correcting the subluxation, shall we?
We should.
All righty. Well, I'm going to wish everyone goodbye. Please like and subscribe wherever you're watching or listening to this, and come back for part two, the correction of the subluxation. Thank you, Dr. Jackson, for joining us, and we'll see
Pleasure.
everybody real soon.
All right. Thank you, sir.